which says a mistake is success in progress, learn and grow. So basically here, as we look at all of us as cataract surgeons, which is our bread and butter, we have grown over the last so many years and we have all grown making mistakes. Even today, after 25 years of practice, we always value each new patient that comes to us. Each eye is different. How the cataract behaves is so different. We need to keep refining our techniques in a way that will suit our patient. In our IC, what we are proposing to do is trying to discuss, analyze in detail, and then have a nice interaction with all of you regarding each step of cataract surgery. Whether it is the first step of biometry, planning, what kind of intraocular lens power to be used, how each different situation can cause errors, how we can overcome it, to the second part of the actual cataract techniques. Haldipukar sir, please come. The actual techniques in each step of cataract surgery, which is so important to give us the best visual outcomes that we intend and plan to give to our patients. Today, with increasing patients' expectations for more and more refractive independence from glasses, we are on the verge of using more and more premium lenses. Whether it is toric lenses, whether it is multifocals, whether it is multifocal torics or the recent EDOFs. How to use these lenses to best benefit our patient, what are the challenges, what are the hurdles that we face when we plan the use of these lenses, which are the patients where we can actually make a mistake, how to go about all these problems is what we are going to discuss in today's IC. And friends, at the end of the 4 talks, we are going to have a 25-minute pure discussion. No didactic lectures, a pure discussion on various scenarios, challenging scenarios, tricky scenarios, where all our esteemed panel and as well as all our esteemed audience are going to give us their inputs as to what we would do in that situation, how we would face that situation, and what best we can do for our patients. So friends, welcome to our IC of A Mistake is Success in Progress, and we are fortunate to have with us the absolute elite surgeons of today, the father of eco-emulsification in India, Dr. Suhas Haldipurkar sir, who has always been a great teacher, a brilliant academician, and has always been so wonderful in giving his inputs. Then we have Dr. Sandeep Nagvekar sir, a very senior, very proficient, and a very brilliant surgeon who takes keen interest, especially in biometry, in toric IOLs, and that is his forte. And I think there's no better person to talk about toric IOLs than him, not only on how and when to use it, but what are the mistakes that we can do along the way and how we can avoid it and how we can manage it. And then we have Dr. Kumar, Dr. Sir. He is the boss and has been absolutely wonderful in all his years of practice. Has taken premium IOLs to a different level altogether. Has been a speaker in national, international conferences and has been the awardee and recipient of multiple awards on various platforms and recent ASCRS award too. So I think we are very, very fortunate to have with us all these excellent speakers, and I'm sure all of us will take back lots of inputs and lots of learnings. I would also invite all of you all to give your inputs at wherever you feel relevant. Ask the questions to our esteemed panelists so that all our doubts are cleared, and we'll try to do our best as much as possible. Thank you so much for being here. We'll now start with the first talk, which is mine, 1 minute, with the biometry. Yeah. Have you put the... Yeah, can we have the presentation on? So the first talk, as we all know, is the beginning as to how we can avoid biometry errors. So today, we are not assuming that all of us have optical biometry. A lot of us are still using immersion, and I think that's very good also. How to use it to the best possible ability is what we need to understand. So there could be errors in measurements of keratometry, of axial lens, IOL formula errors, even as simple errors as manual errors where you may mislabel the IOL, or transposition errors. And yes, you have special situations like of extremes of axial lens where you have a posterior staphyloma in high myopia, post refractive surgery patients which are on the rise, post silicone oil patients. So, a preoperative assessment is very, very important to give us the best precision and greater accuracy in all these areas. Now, when you look at keratometry, we all may be using different modalities, whether it's a manual keratometer or the auto K or the optical biometer. Even in optical biometry, we have the Lenstar, the IL Master 700, the Tomy. All of these use different principles, may give us different readings. Many of us may have multiple of these for each patient, especially for toric IOLs. So, getting reliable keratometric measurements in some of these patients could be tricky, and not all K readings are created equal. For example, if you look at all these, they all measure the keratometry at different points on the cornea. So, it's very natural that they are not going to be bang on and equal in all these cases, but always use the ones that are closest to the center, because that's the most accurate. So, just a few tips for accurate manual keratometry is, first of all, calibrate the machine that you're going to use. So, if you're using the IOL Master, for example, the technician or the optometrist is instructed every day to do the calibration, because until and unless your machine is calibrated, you're not going to get the accuracy and the 6/6 that you are going to need for your patient. Whatever machine works best for you, please continue to use that, but be sure that that is accurate. For any keratometry, it's very important to have a virgin, pristine cornea even before you put in any dilating drop. Obviously, before doing any applanation tonometry or putting in an anesthetic on the eye, so the tear film has to be very, very smooth. A lot of times we do, especially in premium IOLs, taking multiple readings. So we take multiple readings for all our torics, for all our multifocals, and ensure that they are consistent. If not, go back and see why they are not consistent, whether it's an ocular surface that is poor, whether there has been any drop that has been put in the eye, and only be sure of the biometry after they are checked again. If the chemistry is less than 40, more than 48, get it rechecked. If there's a difference between the two eyes of more than 1.5, definitely recheck. And in case of a scarred cornea, maybe you have to use the other eye results, and always do a topography, especially for the premium IOLs. Now, for example, you have this patient where you can see that there is a high astigmatism, but look at the horizontal coma and the horizontal trefoil. There is a pterygium, and that is why you are getting these errors. So be very, very careful. So doing a topography in all our patients of pterygium, we look at the topography and see whether it's encroaching onto the central 3 millimeters or 6 millimeters, and then go on to see what are the higher order aberrations that is having an impact on the eye, so that you can counsel the patient, take a decision whether you want to put a premium IOL in this patient or put in a simple monofocal, whether you want to treat the pterygium first, reduce those aberrations, give a proper prognosis to the patient, wait till the K readings become consistent and stabilize, and then go ahead and do a cataract surgery. Now, for example, a simple patient where you have a dry eye, you go back, even doing a topography, remember that topography doesn't actually only check the cornea, it checks the smoothness of the ocular surface, the tear film. So that becomes a very important test. Whether you're using an ultrasound or an optical biometer, we always know that yes, with the optical biometers, the precision and the accuracy goes on increasing. So if you have more than multiple cases in a month, it's always best to invest in the optical biometer. Again, advantages are, it's a non-contact technique, avoids operator variations, and it measures the center of the macula. So if you compare the two, the A scan will have a 10 megahertz sound wave, and it goes only up to the ILM, whereas the IOL Master goes up to the RPE. So definitely, and we all know how much the precision and accuracy is different. So with the optical biometer, the advantage is you are measuring along the visual axis. So you ask the patient to fixate, and with the IOL Master 700, we all know how you get the central OCT also of the macula. So you're sure that you're going to get the proper fixation and that you're in the right place. So if you compare the accuracy of the ultrasound biometry and the optical biometer, you can see how it's almost 10 times more accurate. So if you are doing a lot of complex cases, if you are doing a lot of premium IOLs, probably it is time to migrate to an optical biometer. Remember, for a PCOL, for every zero point 0.1 millimeter error in the calculation, there is a 0.19 diopter post-operative surprise. So you have to be very, very accurate in all your calculations. Even if you're using an ultrasound biometer, the accuracy is around zero point 0.1 millimeters, and if you have a difference in the two eyes, then always recheck, because these values become extremely important. So how will you know that it is perpendicular? So always ensure that you have all these peaks, equal height, double corneal peaks, the 5 high sharply rising peaks. So it has to be exactly 90 degrees. And then look at the reproducibility of all these peaks. A contact A scan, I think, is outdated, and we should avoid using in today's scenario, because definitely that causes corneal compression and a large amount of error depending on that. The shorter the eye, the greater amount of error it is going to cause. Even in an average eye, we know that a 1 millimeter corneal compression can lead to a 2.5 diopter error. So I think today, if you're using an ultrasound biometry, it has to be immersion. There could be other sources of error like fluid excess or misalignment of the sound beam, a poor fixation. So how do you know that it's not perpendicular? So you can see that here the retinal spike is not perfectly straight. You can also have a sound beam which is not passing through the center. So you know that sound beam is directed at an angle. So here you are not seeing the scleral peak at all here. This is the misalignment here, where the beam is aligned on the optic nerve and not at the macula. So when you're having a printout or when you're doing the test, go back and see the graph, not only the readings, because that becomes very, very important. Again, if you're using the immersion, there could be air bubbles within the fluid. You choose the mode. So suppose you are using both the contact as well as the immersion. Sometimes the mode could be different and you can end up having a gross residual refractive error. It might be sometimes prudent to use individual sound velocities if you have a patient of aphakia, and even if you have a different IOL or when you're planning an IOL exchange, look at the average correction factor for these pseudophakic eyes. Gain setting is also very important. A higher gain setting can help to assess the overall appearance, whereas the lower gain setting will be better if you want a better resolution of the spikes. High myopia is one place where you can have a significant refractive error which is residual. If you have a staphyloma like this, remember an optical biometry will be better, because that gives you directly through the visual axis, and that would be much more accurate and precise. So here, for example, when you're using the ultrasound biometry, the deepest portion of the staphyloma may be located eccentric, and then you may end up having a wrong axial axis. Also, it is better to correlate with the B scan to see whether whether there is a posterior staphyloma or not. Even in the ultrasound biometer, you have the red light, so please ensure and instruct the patient to keep looking at that red light. Sometimes you may have macular lesions which can cause a wrong axial length, and it can lead to an error in the IOL power. Vitreous lesions like asteroids, vitreous hemorrhage, all of these can cause improper spikes, abnormal separation of the retinal spike from the scleral spike, and definitely can cause errors. Having silicone oil in the eye is one area where there can be a lot of error, and we should remember that the sound velocity through silicone oil is lesser than that in the vitreous. So this can cause pronounced sound attenuation and difficulty in even identifying the retinal spikes. So in all these patients of silicone oil, it's better to go in for the optical biometer, which will give us greater precision using the silicone oil mode. So when you're using measurements for the axial length, again ensure that the machine is calibrated. The gain should be set at the lowest level. Again, average the 5 to 10 most consistent results. Remove the outliers first and then go back and take the average. Sources of error for incorrectly short measurements is a sound velocity that is too low, a corneal compression that we discussed earlier, a gain set that is too high, and any cause of macular thickening. Incorrectly long measurements, again, You have the sound velocity that is too fast, the posterior staphyloma, misalignment of the sound beam. Going to the optical biometry, yes, you have the IOL Master 700 or the TOMI, which are the swept source techniques that helps in better penetration, and more than 90% of our patients can be done with the IOL Master 700. But here also you can have sources of axial length error, inadequate fixation. If a patient has nystagmus, be very, very careful, repeat it. And many times we do both optical as well as ultrasound and then compare the two and see that whether they are correlating or not. Correct position is important. Look, for example, here where you are getting an astigmatism of 1.48 at 105 degrees. If the patient's head is tilted, that could be changed. It is 1.56 at 83 degrees. So instruct the technician to be very, very careful as to how the head is placed. Again, here you can see this is a patient of silicone oil where the mode selected is wrong. On the left, the mode selected is just vitreous body, and you can see we have a IOL power of 22.5, whereas when it is silicone oil, it's 25.5. So you can easily get a 3 diopter error if the mode selected is wrong. Now, in patients who have a poor ocular surface, you can see how 3.22 astigmatism in the right eye and 3.67, and there is a change which is very, very significant once the ocular surface has been treated. So today we include dry eye workup also in all our premium IOL patients. Treat the ocular surface if required with lubricants as well as treatments like IPL before you actually go in for premium IOLs. Now look at this patient where you have T3 that is recommended with a 0.4 residual astigmatism, and see the SIA which has been incorrectly put as 3 diopters. Change it to 0.3 diopters and see how the entire toric IOL is changed. So these are various modes of error where even in calculation, if there is a mistake, it can give rise to a residual refractive error. Personalization of A constant is absolutely important. That will increase your precision and accuracy. Choosing the right IOL formula depending on what is the axial length of the eye. And today, Barrett's is absolutely the gold standard. In very, very high myopia, you can use the Bangkok axial length modification. Now, for example, in high myopia, what is the extent of error you can actually induce? On the left, you have the one Barrett which is being used, and you can see it's a minus 0.5 diopter IOL power. Whereas to the right, you have used the SRKT and the IOL power is minus 2. So you can see the amount of IOL power error that you can make by just using the wrong IOL formula. So in the high hypermetropia, for example, on the left you have the Barrett which shows a 31 diopters, and on the right the SRKT which shows a different IOL power. So here the Hoffer Q and the Barrett works well in very high hypermetropia and shorter axial lengths. When you're looking at post-refractive surgery patients, all these errors become very, very important. You have the ASCRS online calculators, the Barrett's True K, not the universal, the True K which is important, the Haig's L in the IOL Master, and intraoperative aberrometry which is not very accessible to all. Just last 1 minute. So you can use any of the forms that you are going to use, whether it's a prior myopic, hyperopic, or a prior RK. And we need to understand the principle behind it. Is basically you are overestimating the K reading in the paracentral region, and that is why you are ignoring the flatter central part, underestimation of the IOL power leading to a hyperopic outcome. So in RK, both the anterior as well as the posterior corneal surfaces are affected. There could be a lot of diurnal fluctuations, so you should take at least 3 readings which are reproducible. And you should remember that there could be a long-term hyperopic drift as well as a transient hyperopic drift in the first few weeks. In the LASIK type, you have the change in the back to front ratio which is different, which can cause the errors. Now, just one example, this was a patient, post-myopic LASIK, always do a topography, look for any decentered ablation. And here we have used the ASCRS post LASIK, and you can see that the average IOL power is 11.95. We use the 12.5. If you were to use the IOL Master, which shows LVC untreated, and you can see even the Barrett and the SRKT are showing 9 and 10.5, which means you are underestimating the IOL power. With the Haig's suite, it's showing 12, which is similar to what the ASCRS online calculator showed. And with the Barrett suite, it's showing 12.5. So you have multiple choices, but use the right formula. Repeat K-metry, repeat readings in case of any discrepancy, and to conclude, correlate the axial length as well as the refractive power. Be sure to check the data in all these patients. So you can avoid errors by taking the right history, whether the silicone oil is actually in the eye, whether previous refractive surgery has been done. Ensure regular calibration, use the correct technique, and repeat wherever in doubt. Also, important to use a very good principles of rechecking in manual errors when you have a busy OPD. Thank you so much for your kind attention. I'd like to now invite Dr. Suhas Haldipurkar sir for his talk on how to avoid errors in cataract surgical techniques.
Uh, Good afternoon, and thank you so much, Dr. Anaga. It's a privilege to be sitting among the elite of today's cataract world, and of course, refractive. My topic is relatively very simple and something that will directly relate to your issues day to day. It deals with common mistakes. Sometimes they are too common to be mentioned, but still, they need to be mentioned because once in a while, even for a senior surgeon, when you're not very attentive, such things do happen. Now, we know that cataract surgery is broken down into different steps, and each step you have done thousands of times. But in part of that, sometimes you can land up with problem. Like incision, rexis, they say your good phaco builds up on each stage one after another. And if you fault in the first step itself, your final results are always substandard or subnormal. Now, if you just have to look at this, incision, if by chance your keratome is not sharp enough or it is too sharp, whether it's double bevel or single bevel, whether it's anteriorly placed or posteriorly placed, sometimes you may get a longer incision or sometimes you may get shorter incision. Both the times it creates problem. So if it's a long one, you have bad overlocking that needs to corneal folds. So once you know when you're making a longer one, you think your incision is becoming a little longer than your comfort level, then you can always come back a bit and redo it. Now this way you are able to. But sometimes if you land up making too short a one, then you always have an issue that it's going to cause you problem halfway through your procedure. Second important thing, if you watch carefully, it's when you're staining it. See, when you stain, your tip is not visible. Not that it happens often, but it happened to me very recently, and it really caused me a lot of concern. Your cataract surgery will take you 10 minutes, but this issue itself, can you notice that? My cannula has touched the anterior capsule and it has torn it at the place I would not really would have liked. Now, what do you do? Now, these are the mistakes where if you can treat it right then and there, meaning you'll have to entirely change the course of your action. And sometimes you get better visibility. You can always use your oblique line because you need that illumination, visibility, not illumination, the visibility, that particular corner, because a critical step, your cut is almost going to the periphery if you can't stop it there. So you may have to go with the micro scissors, you may have to go with the forceps and try and create a continuity in your axis. That's very essential. And then what I do, once I have done that, I have to get it back. So I go with the micro scissors through another side port a very awkward position for you to carry on, and then hold on to that with the microforceps and complete it on other side. So that means a surgery which should have been absolutely uneventful now becomes a major issue, in which the major part of it is taken over by the rhexis. And then by now the pupil is small. So in a small pupil, if you have to do phaco, you are in for larger trouble. So you create you use these hooks to make a sizable sized rhexis opening, and then continue with your phaco, because phaco after that becomes it's easy, and eventually you get your hooks out and carry on with your. Now, this is a case I often show, but I always like to show it because this is a common mistake, not with the novice, not with the seniors, but someone who's just learned and very confident. Sometimes a beginner, after doing 100 good cases, he is little more confident. That's when the complications start occurring. If you notice what happened here, is something that could have been easily avoided. You know, his settings never change, and the way he's holding it, your phaco tip should be buried into the nucleus mass, whereas here it was on the surface of it, so it was tangentially placed, so there was a classic surge. Now what happens if a resident knows at that stage, that's the time he has to calm down, he has to lower down his flow rate, he has to lower down his bottle, and then without taking his phaco tip out, he has to push in viscoelastic. Now that viscoelastic at that time, before the phaco tip comes out, is his savior. Now, as luck should have it, this hole is a punched out hole. Punched out hole is not a problem because it's never going to extend. And then what's a safe side or safe position for your nucleus fragment? It's on the iris. So you just locate it and push it on the iris, of course with a viscoelastic cover. And then if the vitreous is not disturbed, only then you go with the IA. Otherwise, you inject triamcinolone. If you see some stain, go with the cutter, clean it up. Here, not much of staining happening. That means vitreous is not much disturbed. So you take whatever cortex that can be easily taken out, then fill it, and now it's much easier way of doing. But it's still easier in this case is to have some scaffolding, have some protection. Now I have used a single piece lens for scaffolding. Normally when you have PCR and you want IOL for scaffolding, it's always a 3-piece. But I'm using single piece here. The reason is the PCR that I had was a punched out hole. When you have a punched out hole, you're not worried that it will extend. So I can always get my lens back into the bag. So what I do is at the end of it, again put some hooks, open it up, get the lens into the bag. Now, this is very common. Remember, as an ophthalmologist, we are tissue surgeons. When you're a tissue surgeon, you have to respect the tissue. Now, these side ports. Now, imagine if with a bimanual, without changing hands, when the surgeon wants to literally, try and get it out, one thing you kind of, disfigure the side ports. And the side ports, if they are tight enough, they'll close much better without much of hydration. Here in the process, what happens? Because the vacuum and aspiration flow rate is little on the higher side, the PC is caught. This is very common. So that means you have finished your surgery very well. You're so happy, and then for a very pesky reason like cortex, you get this PC. But if luckily that was a small one, so nothing much will happen. But if it's little bigger and a cortical thing falls in, you're honestly worried. So what I share with you is a small twist. The twist is this: respect your side ports and make a mental this thing that you won't cross the midline. If you're on this side, you'll only do the opposite side, but all the time remembering that your side ports are not disturbed. Then I change my hands. And even when the instrument goes in, respect your tissue. See, it doesn't hurt to respect your tissue. By the end of the day, if you want your corneas to be pristine, clear, you have to respect the tissue. Now, I have given enough respect to the tissue, meaning the side ports. My surgery is almost over, and now it's time for me to put the lens. So what happens? After the lens is put in, I just flush it. My side ports will never leak. See, just flush the floor and your wound is closed. Why? That's because your side ports are taken care well. Sometimes, in fact, in my practice, I never do hydration. Wound hydration is never done in my practice because I only hydrate the floor, and it gives me excellent. And with hydration, you have a little bit whitening of the cornea. It never occurs. Now watch it carefully. At the end of the case, your cartridge has not really gone into it. You're not angled well, and this is what happens. Now, if you're lucky, and if your lens is only one third in, you can easily pull it out. But this is a problem. So sometimes you have to literally pull it out. You can't push it in, by the way. You can pull it out. When you pull it out, sometimes there are scratches, sometimes there are the haptic tears. So for that, you have another good way of doing it. Now here, the lens is going in, but you know that something is not okay right at that time. So instead of pulling it out, because your cartridge is also giving you some amount of pull, go with the forceps, just press on it. Now you have two instruments pulling it out, and the lens comes out, and the same lens can be implanted because it is not damaged. Now these are very, very simple ones. Now look at that. Sometimes, if your settings are not good, if you have misjudged your floppiness of your iris, these are the problems you'll end up with. It doesn't matter. If you are in the beginning of the stage, you can treat that iris well. Now, in this case, if I had to start from the beginning and if I had seen the floppiness, I would not use a ring, but I would use a hook. And the first hook would be in a diamond shape, where the first one would be under my incision to take it away from my incision. Anyway, this has occurred. So next time, if I don't want it to happen, what I would do is, at the end of the case, a multifocal or a trifocal lens is put, and the iris shows its floppiness. What I do, I just inject a little bit of viscoelastic because that's very necessary to push it back. And then I go with a second instrument through the side port. Maybe again, I'm hopeful that just the visco will take care of it, but not always. So here I see it's not happening. So this is the time when I don't want to wait anymore, because I do not want to see my patient 6 months later with a depigmented iris there. Very often a patient comes for a long follow-up, operated by someone else or you, and you see those white patches there. That's not good. So here what I do, I go with the instrument, try and press the iris back. Beautiful it stays. No more floppiness, no more prolapse. So these are very, very simple things that you can do. And thank you so much.
Excellent, sir. Lovely videos. And I think each one of those videos, we go back and think how each one of us have been through those situations, and we would actually go back and change our techniques. We'd like to now invite Dr. Kumar, Dr. Sir, for his talk on common mistakes in multifocal LIOL surgeries.
Good afternoon, and thank you, Dr. ANAGHA, to have asked me to participate in your course. It's difficult to speak after Dr. Suhas, who's been a teacher to all of us for so many years, a brilliant teacher. So I'm going to discuss some basic mistakes that make our patients unhappy. To some portion, it is the neuroadaptation of the patient, which we always like to blame, and to some portion, it is us. So I'll try to clear our part. Today's premium life, certain things are a necessity. As Dr. ANAGHA said about immersion biometry, I think contact biometry should be banned. You should never do contact biometry. Either you do immersion or you do optical, but do not do contact. So there are advances in ophthalmology like FLACS. We have advancement in biometry. We have better formulas, and we have better IOLs. So everything is favoring us besides having a good surgical technique. So it's a very old saying that if I had 1 hour to solve a problem, I'll spend 55 minutes thinking about the problem and 5 minutes thinking about the solution. So it's always better that we spend a little more time about how to do it. So do not bargain here. So you have to have proper patient selection. preoperative counseling, a good surgical planning, a preoperative management, and of course, management of expectations. Today morning, I attended one course where it was a very good take home message that when you are counseling a patient for a multifocal IOL, make sure that you develop a rapport with the relative who comes with the patient. We are normally focused on the patient, but I think we have to have a bimanual focus. So one is focus on the relative, because what happens is on the counseling day, the brother comes, and on the surgical day, the father comes, and the father doesn't know anything what has happened in the counseling, and there's complete chaos. So I think this may be a good idea that we concentrate on both. So preoperative homework, do it yourself, test refraction of both eyes. So if there is disparity, you'll come to know. See what the patient is used to reading, what distance the patient wants, helps to know what range that he really wants, and whether he wants to drive at night or not. Slit lamp examination is all the same. Tear film assessment is important. If it is subminimal, make sure that the tear film meibomian gland analysis is done. Endothelium analysis is important. Pupil size, centration, and angle kappa you have to note. Pupil size is important because if the pupil size is very, very small and you put a EDOF IOL, you are going to be unhappy because patient is not going to get any effect. Another thing to know, photopic size of the pupil and the scotopic. Luckily, being in India, our pupils are not large. So what I do is, how do you measure photopic and scotopic? What we do is we have a wavefront analyzer, cover the head of the patient with a black cloth, and then take a measurement. That's the maximum pupil that that patient is going to get. And the same technique I use in LASIK, and my optical zone is decided according to that size of the pupil. Corneal topography is very, very important to know your maximum peak, know your keratometry, whether it's regular or irregular, know your white to white, make sure that the patient does not have any dystrophy or a band degeneration at the level of the epithelium. And astigmatism is very important, that the patient has to be counseled for a toric IOL if necessary. Of course, knowing your retina, if the patient wants a multifocal IOL, there is no doubt that the patients should not have an epiretinal membrane, should not have some aneurysms or exudates around the macula, and we have to do an OCT macula to know that there is no edema. So rule out all the problems. So basically, look at all the red flags as far as multifocality is concerned. So high demanding patients who wears glasses for even small refractive errors, we are the people who will chew your brain up. Okay, particularly animated cataractus, severe dry eyes, knowing high order aberrations at the cornea. We normally tend to ignore this, but it is said that the cutoff is 0.5 microns. So if the high order aberration is very high, avoid a multifocal IOL. Look at angle kappa, which is more relative in a hyperopic eye and not so relative in a myopic eye, because it does not play any role. Astigmatism, inaccurate biometry, Barrett universal formula. So using the right formula, having the right biometer, which normally we have two optical biometers, and both are doing extremely well. Refine your nomogram and make sure that you know that your SIA is good or not. So normally now we all consider our SIA as 0.1. Negative dysphotopsia patients are going to be unhappy. They'll say that they see an arc on the side. Post-operatively, if the patient has blurred vision, you look at everything. You look at whether the patient needs any refractive error, so there was a mistake in your biometry. Look at IOL centration. If a multifocal IOL is decentered, the patient is going to be unhappy. And of course, if there is a PCO, some patients do develop a PCO very early, then the patient is going to be unhappy. So some part I'll tell you about calculation, which I learned over time. What is a good candidate besides ruling out the red flags that I told you? Pre-op planning and technique is equally important. So check every level that you're not making a mistake in any of these levels and any loop that you're missing out. Logical stepwise approach helps in the frame of problem, taking the right steps toward the right solution. And some patients may need an exchange at a later date. I just want to give one example of a high level of toric IOL calculation, which we did. So I have an anterior and I have a lens star. This was a little VIP patient who needed IHANS toric. So in fact, I was the first surgeon in India to implant an IHANS toric much before it officially got launched. This person worked for a very high level company, so he could manage to get the lens in. So you can see that the patient does need. So I've done a pentacam, I've done an anterior, and I've done an IOL master. Okay, and let us look with everything works and all the formulas are matching or not. So you have to do, so we do 4 formula calculation for each patient when he needs a multifocal. You can do SRKT, you can do Barrett, and you can do Barrett universal, and of course Hill RBF. You can have an optical biometer. So here, as per the Hill RBF reading, I need this, and according to the IOL master, you need this. So I've here compared 2 optical biometers. Both are needing the same amount and the end result is almost the same. So toric calculation went the same way, and it worked very, very well. The post-op patient, so here I can show you my sheet. There's an anterior, there is a lens star, there is an immersion if necessary, and you can do calculations according to the formula you want. Ultimately, I used an enhanced toric, and the patient was very, very happy. But one important mistake where we can make is knowing the ACD. Now, many people do not know this, that ACD plays an important role in effective lens position, and so the cylindrical power at the corneal plane can really change. So, there was a study done long time back that if you have a deep ACD for a given toric IOL, will correct a lower amount of corneal cylinder than the one with a normal ACD. Conversely, in hyperopic eyes, the same IOL will correct a higher amount. So, when you have a toric IOL, do concentrate on the ACD. If your ACD is just an example, important to consider hyperopic ACD of 2.54 and you are calculating toricity, you will have two different formulas with two different toric powers. So which one will you select? So without ACD and with ACD, so you can see that the whole lens actually changes from a 2.25 to a T3 while considering the ACD. So some studies have said that it really doesn't matter, but whatever little experience I have, that it has said that it's better to look at the ACD when you have a toric IOL, and the calculations are much more accurate. So posterior corneal astigmatism, as far as multifocality is concerned, is also very important. Previous calculations, we did not bother about this, but now if a patient wants multifocality, besides doing your routine retina, cornea, high order aberrations, also look at posterior astigmatism. And many studies have found that posterior corneal curvature varies amongst different individuals. So ignoring it completely will give a wrong result and make the patient unhappy. We also know that with age, the anterior astigmatism moves horizontally, but the posterior astigmatism is really not affected. So the posterior corneal astigmatism will compensate anterior corneal astigmatism in a younger population. So we also, just to put it very simple, don't get confused by all this. If the patient is with the rule astigmatism, undercorrect by 0.5, and if the patient is against the rule astigmatism, correct it completely. Okay, just remember this and that should be fine. So anterior corneal surface which is in contact with air has a positive refractive power, and the posterior corneal surface which is contact with aqueous has a negative refractive power. Hence, a vertically aligned steep meridian on the posterior corneal surface generates against the rule, that is, and that neutralizes some part of the corneal astigmatism, and it's exactly opposite when it comes to the posterior. Just a simple example, that if the meridians of the anterior and posterior corneal astigmatism are the same, posterior corneal astigmatism reduces the anterior corneal astigmatism as it neutralizes it. And if it is exactly other way around, it will increase your astigmatism. So just remember this, that do not ignore posterior corneal astigmatism. Look at it and look at it for your calculation. Just one example here, I've got a femtorexis. If you are having a femto, believe you me, it's like if you don't have a Lamborghini, you don't know how the car drives. If I had my own eye to be operated, I would 100% select flax. Not saying this because I have it. I'm saying this because it has phenomenal advantages. Flax can make your incisions. Flax makes your CCC perfectly on your visual axis. I also know that the IOL centers in the center of the bag, irrespective of where you make your rexis, but having a perfectly round rexis can also have a rescue phenomena. So if you have a PC rent, the CCC will really help you to save your IOL, and you can do a reverse optic capture. So you can see a trifocal IOL going perfectly into the bag, and it centers automatically. When you do a manual CCC, you have to nudge the lens to center it. But when you do a CCC through flax, it automatically centers, and it's very important to remove the viscoelastic from behind the IOL as far as multifocal IOLs are concerned. So these are simple things that you have to look at calculations. So in conclusion, a good pre-op examination, a surgical process which has to be perfect, and a post-op looking at your results and analyzing what your SIA, etc. is, will make a patient very happy. Thank you very much.
Thank you so much, Dr. Kumar. Yeah. Thank you so much, Dr. Kumar. I think that was a very, very exhaustive, detailed talk. And as Dr. Nagvekar sir is loading his presentation, I think one of the common mistakes, common mistakes in multifocal IOL is the selection of what kind of IOL we need to put. Today we are spoiled for choice with the number of trifocals, the bifocals, the older bifocals that are available, and the EDOFs that we have today. So I think we should become a matchmaker and actually speak to the patient regarding what exactly he wants, what is his day-to-day functional requirements, and then tailor make each IOL and the surgery to his demands and needs. So we'll have a discussion on this later again. As of now, Dr. Nagwekar sir on common mistakes in toric IOL surgery.
Thank you, Anagha, for inviting me for your course. Thank you, Kumar, for making my job a little easier. So, just to outline my talk, I'm just going to basically enumerate some of the common mistakes that we carry out preoperatively and intraoperatively during toric IOL surgery. We look at ways and means of how to prevent these mistakes from happening. And as we go along, and once we realize you've done your surgery, in the end, we'll conclude by trying to repair some of the mistakes we do. So, to begin with, do we really make serious mistakes in toric IOL surgery? I have not seen a more forgiving surgery when it comes to monofocal torics. If it comes to multifocal toric, of course, it's a different thing altogether. But one thing that is very sure is that patients' dissatisfaction with this procedure or with the doctor performing it is extremely unlikely. So we actually begin on a good ground. So what are the common mistakes we do? The first mistake that we very often do is choose a toric IOL when it doesn't need to be done in the first place. You make errors in biometry, you can have errors in execution and errors in calculation. Errors in calculation followed by errors in thing. So look at the topography in each and every case. So if you have a regular astigmatism, which shows a symmetrical bow tie, this is an ideal case for a toric IOL. But sometimes you get a case like this where there is an asymmetric bow tie. This is not a very ideal case, but you may still escape. But what happens when you get a case like this? Now, this is not a case which is suitable for a toric IOL. Errors in biometry. The first thing that we have to do is that we must do the biometry before we put in any local anesthetic in the eye to take the eye pressure or before we put any dilating drops. Have a close look at the ocular surface. In fact, if there is a patient who has an obvious ocular surface disorder, this biometry should be postponed till this thing can be done. And use a keratometer that measures the K values within the central 3 millimeter zone. If you have a keratometer which measures outside, like an autokeratometer, this is not likely to be used. And once you have done the biometry, immediately assess the tear film by doing the T-butt and the Schirmer's 2 test, and look on the slit lamp whether there are any clinical syndromes like a punctate keratopathy or a meibomian gland dysfunction, which may render this case unsuitable for the biometry itself. Now, when it comes to biometry, as all my previous predecessors have explained, there is no biometer which is as good as an optical biometer. That is the first thing that you must have when you're doing toric IOLs. And if it comes to even on the optical biometer, it's very important that you look at the patient from the side as well as from the behind to see whether there is a head tilt, from the side to make sure that the lateral canthus of the patient is aligned with the reference mark on the machine instrument that you're doing. And even after you've done that, you make sure that the patient is looking straight ahead, because if the patient is looking upwards and not at the fixation light, this is the kind of reading that you'll get, which is not suitable for your case. So K readings on multiple devices are to be encouraged. I mean, don't just stick to one instrument, take measurements from several instruments. And while these instruments might differ, there may be some pattern that might emerge, which might be clear for you. A lack of consistency amongst all instruments is a red flag. You have to keep on looking at this and probably improve the ocular surface and take the readings again. And if you have multiple readings, you can also integrate all these readings on the Barrett toric calculator. The posterior corneal astigmatism should be measured whenever you have either a Scheimpflug device or you have a IOL Master 700 TK, which looks at both the anterior and posterior curvature. Why this is important? Because the posterior corneal astigmatism I've seen can vary right from a 0.1 to 0.7 diopters against the rule. Remember that the Barrett toric calculator assumes a 0.3. So if you have a 0.7, you need to tweak your IOL power. So therefore, if you can have a look at the posterior corneal astigmatism in all cases, it's a big help. Errors in calculation. A very, very common mistake done by all optometrists is to have a wrong entry. Sometimes there is a flipping of the steep and flat axis. They're so used to saying things as K1 and K2. Now K1 may be 45 and K2 may be 44. So in that case, you know that this is against the rule astigmatism, and this will be flipped in exactly the opposite. Incorrect surgical induced astigmatism is a very common mistake. You have planning for a certain meridian and you're planning for a certain SIA, and you probably put that incision, as I'll show you an example, superiorly, or if it's a longer incision, then of course the SIA would change. And of course, do not use a calculator that does not consider the posterior corneal astigmatism. That's a given thing. Now, I'll show you one simple example. This is when the toric calculators came long back in 2007 when I implanted my first one. And you can see that the option given to you is a T4 model with the anticipated residual astigmatism of 0.45. So now you don't go strictly by the calculator, use your common sense. If you use a T5, the anticipated residual astigmatism will be less. This is because these calculators at that time spoke only in terms of positive residual astigmatism. Now switch back to 2023. Now we all use the toric calculator. Now I'll show you this example. I always operate a 2.2 millimeter incision in the temporal zone, and my surgically induced astigmatism is 0.1. Now, in this particular case, what happened, there was a fleshy pterygium on the temporal quadrant, and I was not going to. So I just told my, my optometrist that I will be operating superiorly. See what she has done? She's put the incision at 100 degrees, which is comfortable for me, but she put the incision SI as 0.1. Now, there's no way that a superior incision will even give you a centroid value of 0.1 with a 2.2 millimeter, except when it is done in the temporal quadrant. So this is obviously a mistake that has happened. So, and there is another example where I want to show you, if you can read from there, the options given by the calculator was a 22.5 diopter lens for a minus 0.07 spherical equivalent. For a SN682, the residual was plus 0.16 at 176. And for the SN6T3 model, it was plus 0.17 at 86 degrees. Now, which one would I choose? The obvious answer to this question is that if I were to put in a monofocal toric, I'd probably put in the first option, because a little bit of residual against the rule astigmatism will help to give this patient a good depth of focus. But on the other hand, if I'm going to put in a multifocal toric, my option should be T3, where I will be converting this patient to with the rule astigmatism, so that even if this astigmatism decays with time, this will be helpful for the patient. Errors in execution. Errors in execution come because of incorrect reference marking, because of intraoperative complications, because of incorrect alignment and rotation of the IOL post-op. So one very important tip for those who are making markings is that probably do this in the sitting position. Use a speculum to keep the lids apart. So you're not holding your lids apart to make those marks over there. The speculum put in also dries the cornea, which is very helpful for putting those marks on the cornea. The peripheral cornea should be indented and inked rather than the conjunctiva, which is mobile at the limbus. And after you've done this, you must verify this on the slit lamp, like you can see in this case, before the patient is moved into the OT. So this is the preoperative thing. Make sure you put the marks, make sure that when you make the slit lamp vertical and horizontal, it is aligned with those marks. If it's not aligned with those marks, then you go in and make that little change. You rotate the slit lamp, see how many degrees of rotation has occurred even where you are marked. Don't assume that your mark will be perfect. Or you can use this particular app, which is the iToric, Dr. Patwaran's. You have made those marks over there, and then you use the gyroscope of your ordinary mobile phone, which shows that your marks are not aligned. You now know how you have to place the lens, because he also provides you where you need to put the lens. If you're using a markerless system like the Varion, you have to make sure that the picture that you have chosen for your reference marking should be with the eyes open full, not with the eyelashes covering the cornea and where the blood vessels are indistinct. This is another source of error which comes in. Intraoperatively, in case you have eventful surgery, there is a posterior capsular rent, there's a vitreous disturbance, or there is a zone dial, ask yourself whether you want to put the toric IOL over there. And one other important thing which completely throws the surgically induced astigmatism out of gear is a corneal wound burn, which might sometimes happen with a hard cataract. During surgery, you have to make sure that whether you use a markerless system or you use the axis marker, make sure that at the end of the surgery, you have aligned those marks very well, as you can see over here. And do this after you have aspirated the visco under the IOL. That's even more important. Rotation of the IOL post-op always happens because you have left some visco behind. So make sure that you have aspirated the visco very well. As soon as the surgery is over, you come outside and again put the patient on the slit lamp to make sure whether you have got it right. Because nothing is as good as a slit lamp for giving you the accuracy of your IOL placement. In case the rotation is more than 5 degrees, it's your business to go back again and put this thing properly in the bag. Now that we have enumerated the complications and ways to prevent them, Let us look at what happens once the surgery is done. Look at the patient's uncorrected visual acuity. The most important thing is not 20/20, but whether the patient is 20 happy. If the patient is 20 happy, I don't think you need to do anything further, because a small amount of residual astigmatism is beneficial, especially in those people who you're putting in a monofocal toric. Which cases to treat? I'll just take 1 or 2 minutes. Yeah. Which cases to treat? So if those cases is a multifocal toric, these are my low threshold cases. These are cases where I will go in and intervene. So if the patient is a multifocal toric, has got an oblique axis, has got a residual hyperopic or a mixed astigmatism, if the patient's best corrected visual acuity is 6.5, then this patient knows, even if the patient's unaided vision is 6.9, he knows that he has a potential for getting better vision. So if you're, even if it's 6.9, don't give it up. You see what is the patient's best corrected vision. Look at what the surgically induced astigmatism was chosen. Maybe it was incorrectly chosen. Or when monovision is the goal. Monovision is again an area where you got to be spot on. So if you're not spot on, you got to go back. What are cases where there is a high level of tolerance? It's just the opposite. Monofocal torics, where the astigmatic axes are horizontal or vertical, when the residual astigmatism is myopic, and where the best corrected visual acuity for whatever reason is 6.6 or less. Analyze your refractive error. You have to do the post-op refraction, look at the post-op K readings, look at the post-op axial length reading, look at the post-op ACD, again very important, as Kumar just told you, and look at the post-op IOL power calculation. Now, if the IOL power calculated is correct, you just go back to the toric calculator, put the post-op case as a pre-op K, induce the surgically induced astigmatism if you're gone in by the Barrett toric calculator, and simply dial the lens to the new axis as suggested by the calculator or as suggested by the post-op cylinder. If the post-op K is as expected, then these are the possibilities. Either the residual cylinder or the sphere was high in the calculations, the IOL rotated in the immediate post-op period, or you did not place the IOL in the first place in the correct axis. There was a significant PCA which was overlooked, or there was a combination of these errors. If the post-op K is not as expected, then there was an error primarily in your data calculation. There was an error in the data input. Maybe there was a flipping of the axis. There was an unexpected SIA, as I told you, due to wound burn, due to unexpected surgical complications, or there was a complication of the error. So how do you manage the residual refractive error? In case of a flipped axis, just rotate the IOL by 90 degrees and you're back in the business again. In case the spherical equivalent is 0, LRI can be attempted. For all other errors, either you rotate the IOL, or you do an IOL exchange, or you piggyback this IOL as suggested by the Barrett RX formula. One more wonderful armamentarium in the Barrett suite is the Barrett RX formula. So you put in the post-op case with the major and minor meridians along the axis, put in the pre-op case, put in the IOL power model, which was put in this case, T4 model was, so you input all these things, put in again your surgically induced astigmatism, your wound incision, and the output given to you that probably you should have used a T5 in the first place and not a T4. He also gives you a kind of a graph where you can know that if your patient was placed at 90 degrees, if you put that axis at 20 degrees, you are probably going to get the least minimum residual astigmatism. If nothing else works, then in those patients where the patients don't want further interventions, or there is a problem with the IOL stability because of a zonular dialysis or some other problem, then in that case you can always do a LASIK to correct it as a bioptic procedure. And if nothing else works, then glasses is always an option. So do consider that. Thank you so much.
So much, Dr. Sandeep. It was an excellent presentation and lot of learnings. Now we'll go on to our next part of the IC, and that is panel discussion. Can you please connect this? And then we will have questions from the audience. In this Thinking on Your Feet session, I would like an active participation from the audience also. If you have any point that you would like to ask or give your inputs, you're please feel free to give your inputs on this. Yeah, after this. Yeah, we are completing in 25 minutes. Yeah, so this title is Thinking on Your Feet. So, the first question to our panelists, here is a patient where you have operated, it's an uneventful surgery, intra-op. It's a trifocal patient, and you have a post operative refractive surprise of minus 3.5 diopters. The patient has come to you second day post op. What will you do? How will you face this situation? What all will you look for? Aldipurkar sir, Nagvekar sir.
Well, if the post-op refractive surprise is 3.5, and if the surgery on the slit lamp looks uneventful, then it's really a surprise. So, uh, I
What
cannot.
all will you look for on slit lamp, sir?
Now, obviously, with 3.5 spear, well, I mean, in the post-op on a slit lamp, you see the position of the lens, whether the AC is shallow,
Right.
whether the lens is pushed forward, and or I would also look at the fundus to see if there's some edema posteriorly, where somehow the thing has been. But then, if things look good, so we obviously know that it's a case of missed target, and in that case, counseling wise, obviously on the first post-op day, he won't come to me unless I have operated. If I operated this patient and comes to me on the first post-op day, well, I kind of tell him that, look, I mean, I can't tell him 2 weeks later, let's see, things will improve. It's probably not going to improve because it's too much. So I would say there seems to be some amiss here. And if your, your refractive error doesn't really come down, we may have to go in for another procedure. That's what I would say.
Yes, but before we even go on to the counseling,
Shall I?
now, like you very rightly said, if there is a, yeah, Dr. Nagvekar sir, yeah.
Hello. So, I think I would.
How would you
probably-
approach this case?
Yes, I would probably, but be a little more aggressive than Dr. Suhas. In the sense that what I do is the same thing that I told you all in mistakes in toric IOL surgery. You go back and do the biometry again. Of course, after finding out on the slit lamp that the anterior chamber depth is as expected, then the only other possibility that I can think of is either a mislabeled IOL, okay, or there was a wrong biometry. So in which case, I am going to do the biometry again.
So the first step is on slit lamp, you look for a wound leak. You see if the anterior chamber is shallow, which means that the lens has moved ahead.
Yes.
So the anterior chamber is shallow, IOP would be low. Probably there would be a few fine corneal folds which say that the IOL power is right, but it is the anterior chamber depth which is reduced, which has induced the myopia.
Correct.
Correct? So that would be the first differential diagnosis. Now suppose the anterior chamber is mildly shallow, and would you think of a capsular distension syndrome in this case?
Not so early.
Why not?
Capsular distension syndrome, at least as what I understand, is something as a complication of a posterior capsular opacification.
No, sir. No. What I'm saying is, you have done an excellent rexis, but there is a 360-degree overlap. And the capsular distension syndrome is where you will have fluid accumulated behind the IOL and between the posterior capsule.
But you're talking of an
that will, yes, but it's not a wound leak.
You're talking of an aqueous block on the CCC, correct?
I'm talking of a capsular distension syndrome, not even a misdirected. So basically, it's not a wound leak. It's a capsular distension syndrome because the CCC has completely covered the IOL, and now there is fluid that has, see, many times when you're doing the last IA, there could be a little fluid behind the lens. We have had such situations in the past.
Fluid behind the lens would always be there if you're seeing a shallow AC and the wound is good. So that means what you want to say is there's a lot of fluid behind.
Yeah, so if you do an OCT, AS OCT for these patients, you can see a difference in the space between the posterior capsule and the IOL. So you know that it's not a wound leak, but it's a fluid that is accumulated. So the entire thinking process and the treatment line would differ. Then you would not want to do an IOL exchange, but you would want to remove that fluid.
You would anyway wait.
Yes. So now you would wait for that fluid to get absorbed. Maybe you would start the patient on, you would probably step up the steroids, see for a few days, and if it doesn't, then you would go back and tap the lens to get the fluid back anteriorly. So that, or and remove that fluid. So we have had a patient like this where there was no wound leak, but there was fluid accumulated behind, causing anterior shallowing and the IOL coming forward, diagnosed on ASOCT. So we waited for 2 days. It didn't stabilize at all. It didn't reduce because there's no place for that fluid to go. So we went ahead and just tapped the IOL. That fluid came out, gave it a wash, and then the patient was fine. So this is something that you just need to remember, that it may not always be a wrong biometry. It may not always be the wrong lens, which also you should remember, but it's just how to go on with once you see a patient like this. So suppose everything else was normal, then probably you would go ahead and do a pseudophakic biometry and then check whether the IOL power was right. Am I right, sir?
Yeah, that's what I was thinking.
Yeah.
I
So
would
if
do a
this was not the
pseudophakic
case,
biometry anyway,
if the
because it's
anterior
this-
chamber depth was normal,
yeah,
then you would do a pseudophakic biometry and check whether a wrong IOL has been put
or a mislabeled IOL.
or a mislabeled. And then there's probably no other option with a 3.5 diopter. There's no other. So now if it's a wrong IOL, at what point of time would you an IOL exchange? Immediately?
Yes.
Because you have no option.
Yeah.
3.5 diopters is not something which you would keep.
No.
At what point of time? Suppose instead of 3.5, it was a 1 diopter -1, say for example. Would you wait till a month for it to stabilize and probably do a touch up, or would you do an IOL exchange? Because this is a trifocal.
For a -1, obviously there's no interaction, intervention done immediately. And your post-op biometry has shown that things are okay, then you definitely wait. Even if the post-op things say that, well, you have missed it. Even then, whether for -1, would IOL exchange be your treatment of choice, or you would go for less invasive ones?
What is
Like
your
if it's
take?
3.5, 4 and all, then obviously the patient needs IOL exchange, and then there's no point in delaying it any further.
Yes.
But if it's -1, maybe for 1 month, I wouldn't do anything.
So because the more you wait, the more the fibrosis would occur along the capsular excess margins, and the more difficult it would be for an IOL exchange. See, when you're doing a trifocal, the patient has been, his expectations are sky high, and he is saying that he's not able to see. So his vision, uncorrected, would drop to 612, 6.9, and he is not happy. So for the next 3-4 weeks, till the decision of IOL exchange or a laser touch-up, he's going to come and eat your head at every visit. And you know that you have missed target by 1 diopter. You know that it's probably a wrong biometry. So at what point of time would you take that decision? Because if you wait for a month, then at that point of time to do an IOL exchange would be more difficult than by doing it in the next week.
So I think I would start talking to the patient immediately. See, there's no point in keeping the patient in the dark or saying that, this will improve, when we ourselves are not sure whether this will improve or not. So probably I would talk to the patient and open up 2 possibilities here. One could be an IOL exchange at the end of it all, whatever the time period may be, or maybe even, introduce the concept of bioptics. A 1 diopter, if it is bothersome, I would not hesitate to do a surface treatment for such patients.
So one more question, if you're talking of LASIK or ASA,
Yeah.
in this patient post-op, it's already a multifocal diffractive technology trifocal, where the contrast sensitivity has already reduced. Now we are going to introduce a multifocal, on the corner. So
Just
how are
one
you?
diopter. One diopter will not make. I've done. That's why I'm telling you. One diopter. The problem with that particular patient, I remember, was that his halos were terrible. Once you land up with a diffractive multifocal and you make the patient post-op myopic, those halos increase tremendously. So in this patient who was more than 6 months post-op, okay, we discussed this possibility. It was not operated by me, mind you, but it was a very, very good, well-done surgery. So we did not hesitate to offer him a surface treatment. We did a surface treatment, and I think the patient was overjoyed, because with one diopter, I don't think, how much
But
tissue
after
are you going to
LASIK,
remove?
if the glare and halos would have increased, then how would you have?
No, with one diopter, hardly any tissue being removed.
Okay.
Yeah.
So
And
we'll
with
move on to the
due
next
respect
talk.
to surgical skills of anyone, IOL exchange is not a cakewalk. And to do an IOL exchange, if your original incision has been 2.4, you can't get the lens out to 2.4. You have to make it either 2.8 or 2.9. And in doing that, and in the process of getting that lens cut and taken out, some amount of corneal aberrations do happen. And then you're going to put another lens. And this time, you have caused little more surgical induced astigmatism. So it is extremely difficult to titrate it. So unless it's a big refractive surprise where the exchange is better than a surface or LASIK treatment, I would opt for this.
Okay. We move on to the next case. A 54-year-old female, one eye operated elsewhere with edophavity, unhappy with the near vision, maybe because she was not counseled that she would need a reader. Wants better near vision, has come to you for the other eye. Now there's already an EDOF in the first eye. What would you do for the second eye?
What is the unaided distance vision in this first eye?
Distance vision is 6 by 6.
And what is the near vision?
Near vision is in
24.
24.
And 18.
I mean, definitely not happy reading at all, and all she wanted was good reading. So this is very, very important. This stresses on the importance of counseling when we are using EDOFs, because most of them are not aware. They just feel that they will get more multifocality, but they are not aware that they will need a reader. And now you have to operate. And in fact, she's also saying, what can you do for the first eye? And she is almost 3 weeks operated in the first eye. How would you, and now there's cataract in the other eye. What would you do for the other eye? What would you use?
Yeah, first of all, this patient should not have been probably counseled for the EDOF.
So,
if
but
she was a
elsewhere done
on,
elsewhere. We don't have
but I'm just
control
saying-
on
I'm
that.
just saying,
Yeah.
if suppose a patient comes to you primarily and tells you that I want to read without glasses, okay, then I don't think you should promise an EDOF unless you're doing some kind of monovision with these patients. That is one. So I asked you, what is the first refractive error? So if she's emmetropic in the first eye and I have to put in the other eye, counseling her completely about everything that can happen, I'd probably put in a trifocal in the other eye, because that's my best bet of giving her visual goal, which is to read without
Which
glasses.
trifocal?
I think
And we have
put
no
her-
financial interest here,
Yeah,
so
yeah,
we can.
please, yeah.
This
So-
is for the benefit of the audience. Which trifocal?
So now if the patient's eye is absolutely healthy in all respects, doesn't
Yes,
have
it
high
is.
order aberrations, doesn't have dry, has a pristine macula,
Yes.
I think I would probably put in a panoptics as my first choice.
Haldipurkar sir?
Well, I would, after having used all the lenses, if you want to be absolutely sure. But then in this case, whether I would put a trifocal is a matter of discussion, because in the first place, probably I put EDOF because EDOF is a better quality. Now, after he has experienced a clear quality
Wants,
for
sir,
distance,
patient wants good near vision. She's not happy. She doesn't want to use glasses for
when she
reading.
says she wants good near vision, which doesn't mean she is okay with distant vision.
No, she's okay with distance vision, but she doesn't want to use
No,
glasses for reading.
The human tendency is whatever is good is not mentioned. Whatever is subnormal is mentioned. So in this case, if the patient says my near vision is not good, at that time, before if I put trifocal, if I do not tell her that with trifocal, you'll always have the difference between trifocal and VBT distant vision. I think.
So, but with a trifocal, you will get good distance vision.
Not when you compare it with a
Yes.
non-refractive lens.
Agreed. So, what we had this patient, and we explained to the patient that only with a trifocal she will get good near vision without glass. But obviously, the principle of the IOLs in both the eyes will be different. So, she should not compare each eye, both eyes, all the time. We went ahead and put in a synergy. She got very good near vision. But then she kept saying that, can you do something about the first eye? Which we said, no, we cannot do anything. Your vision is good for distance. We just forget about it. So now, without glass, she's reading 6.6. Without glass, she's reading N6 with the second eye. She's happy as of now. We had explained to her that there could be glare and halos which would be different because we had put in a trifocal, the contrast sensitivity would be different, but that she will have to accept. Otherwise, if she was not ready to accept that, we would have put in an ADOF with micromonovision, but she was not ready for that. She wanted good distance vision also. That is why we did not go in for a micromonovision. She was very clear that she wanted to read without glasses.
At the end of it all, she's happy.
She is very happy.
Then
So-
forget it.
In this, Dr. Anagha, I would want some discussion, if it's relevant, on the dominance. Now, presuming that patient was right eye dominant, then she had better chances of being happy because the left eye is used for near. A dominant eye is having a good quality. So having said that, do you believe in your practice in the dominance of a particular eye?
Not really so much.
Not really. What about you?
So, yes, even I don't pay too much attention, but once in a way you need to. It is very difficult, actually, as I'm going to say in the next course, to find out what is the dominance in a geriatric age group with cataract in both
With
eyes.
cataract.
How are you going to check for dominance? It's very
It
difficult.
may not be reliable.
Yeah. You just ask some certain things like which eye do you close when you have to shoot, or which eye do you put to your hand when you're seeing through a pinhole. So those are very gross methods, and it's very difficult to do that. And
No, but that will not matter as much
yeah,
as when you are going to put different quality lenses in two eyes.
that is true.
Presuming
Yeah.
this patient was left eye dominant, all right, no, right eye dominant, and the EDOF was put in the left eye because left eye was operated earlier. Okay, and now for the right eye, you're going to put trifocal lens.
Yeah, but then I think I would still put, because she said unaided EDOF vision was 6.6.
Was 6.6 for distance, yes.
Unaided EDOF vision, the eye with the EDOF had 6.6 unaided vision for distance.
Yes.
So I think you can probably, I mean, there has been a compromise all along. So a small compromise may not matter too much.
But
Would
what
you
will
be
happen if you
concerned,
put EDOF with monovision?
She wanted good distance vision also. Her only work was watching television and mobile.
And eating the doctor's head.
Very good near vision. Why synergy?
Yes, sir. But then
Even a
synergy,
minimal proxy would have done the
we
job
had.
for
See,
near.
I actually measured. I asked her to hold the mobile at 30, and she held it, and we measured it. It was perfectly 33 centimeters. So I thought at that point of time, synergy would give the best results.
Another option can be minimal proxy.
Minimal
also.
proxa,
Yeah,
yes,
that's
but
a good
that's
suggestion.
a good suggestion.
Monofocal lens, the distance is good with one eye, the other eye we can manage with this.
Lucidity is
So
also
coming to
has
the
a
next-
+3 act.
Yes.
Lucidity is also has a +3 act.
So coming to the next case, a 50-year-old female with 18 cut RK, and one of the flattest case that I've ever seen, around 27, 28. Now, in these cases, sir, what IOL power would you use? Now, this was the ASRS online calculator. You can see it gives you 3 readings below: the average, the minimum, and maximum. This was an 18 cut. So, what IOL power would you use in this patient? The average is 26.76.
I think I would put a 27.
Sir?
See, obviously, it's not the number of cuts that we go by,
Yeah.
but the number of flatting that has occurred, and it's quite severe. So, obviously, the principle is to go for whatever it says, go for a little higher. So, probably I would.
So the maximum is 26.8 here. Minimum is 26.76.
I would even go for 27.5, 28 also.
Okay, so here we have also put in all the Atlas ring values also. What we used was the 28. And this was the surgery. So always target myopia in post-RK patients. And I feel greater the number of cuts, probably the target myopia should be slightly higher. So I'll just stop here, sir. This was, you can see the number of cuts here. What kind of incision would you take in this patient? Even for a 2.2 millimeter incision, there's hardly any space. So ideally, probably a posterior limbal or even a scleral incision. Here, the mistake that we made was we took a limbal, but then it opened up. So if you have multiple cuts like this, probably during the surgery, look at what happens here. even the side port, for example, because there were so many cuts that there was no other way. So one take home message here is, when you have too many cuts, it's better to take a scleral incision. There's less chance that it will open up. One controversial topic here is, would you use a toric IOL in a post-RK patient? Yes or no?
Only if there is some degree of symmetrical astigmatism.
Anybody here using toric IOLs in post-RK patients? So before we go ahead with the next case, we have used many toric IOLs in post-RK patients with very good results. But you need to do a complete workup. You need to do a topography. You need to do a holiday e-care report. See whether it's a symmetrical astigmatism under severe guarded prognosis. And we know, yes, that there could be residual refractive error. You have to explain to the patient, and then you can still go on. Now, coming to this patient, a 52-year-old, undiagnosed keratoconus. Now, let's concentrate on the right eye as of now. Look at the K1 and K2. It's 47 and 59. So it's almost a 12 diopter astigmatism. Patient has come to you for cataract. He doesn't know that he has keratoconus. The left eye is so severe that it's not even recordable. And he felt that he was amblyopic in that eye, not diagnosed as keratoconus. So if you look at the topography in the right eye, it's fairly regular but very steep case, 58 and 47. So astigmatism is almost around 11. What would you do for this patient?
Since this patient shows pretty much a symmetrical astigmatism, and however large it is, I would probably ask one of our Indian companies to customize this IOL for me. I'd probably put in a customized toric for him.
So would you use a toric IOL in a keratoconus patient?
Yeah, yes, of course, I would. This patient definitely.
So this was the pentacam, and here, as you can see, even on the pentacam, it's fairly regular astigmatism. And this was the A scan done on IOL master. You can see the astigmatism is 12.38. And we first went ahead and tried on the Barrett toric calculator, and even with a T9, the residual astigmatism is 7 diopters. So obviously we cannot use a routine toric IOL. So then we went ahead and planned for a smart toric. So a smart toric IOL, anybody who has used the Ultima Smart Toric?
Yeah.
Yeah, so it is something which you put in at 0-180 only, and the incision is also at 180, and here you can see anticipated residual astigmatism is 0.14. So we are targeting correction of almost a 12 diopter of astigmatism very easily with this smart toric. So it's specially customized. It probably takes a few days, but it gives excellent results. So this was the smart toric calculation, and this was the patient post-op. So from a 12 diopter, we were able to bring it down to 6.9 plano. You can see the two markings also, they are at perfectly 0-180, and the patient had a very good result. Coming to our next case, case 5, patient of childhood trauma now has come to you for cataract, and you can see how the pupil is updrawn. How will you manage this case? Haldipurkar sir?
Well, some more information would be needed. What's his the trauma has caused what, some corneal laceration?
She doesn't give any proper history. She doesn't have any old papers. All she says is she had some trauma, following which the vision in that eye has been poor. Right now, vision is finger counting. It's a very advanced cataract. So we know the cataract itself could be the cause of this blurred vision.
There
She
could
wants
be some amount of amblyopia in this eye.
amblyopia, that she is ready to accept.
Depending on the corneal status. If the cornea is symmetrical in this, then your focus is only on cataract.
Yes, cornea is fine.
Cornea is fine. Then it's a state where it depends on how much the pupil dilates. If the pupil dilates well, it doesn't matter. If the pupil doesn't dilate fully, then these are the cases among pupil expansion devices. It's the hooks that work best in these cases, because you need only to pull down the pupil.
So the pupil dilated well. Now
well.
the problem is here, what I'm specifically alluding to is
Okay.
the position of the pupil.
Okay, in that case, what you need to do is spectrotomy. Using a cutter, you can make, if at the end of the surgery, the cataract surgery is done well and the pupil comes back to this position after
Without
putting pilocar,
sphincterotomy, because we don't want to,
See, you
otherwise the
can,
pupil will
you
remain
can
dilated.
see, you can, what I would do at the end of the surgery with the forceps, with the micro forceps, I would pull at 12 o'clock. And very often, even in traumatic mydriasis, if you try and pull it down, those adhesions break and the pupil does come down.
Any
So,
other input as to how you can do, what would you do for the pupil?
We have to do a gonioscopy
yes,
before
what is called.
and do a UBM. So you'll also know the status of the zonules.
All that is fine.
All that is fine.
All
sir.
that is fine.
Then,
But
actually,
you mean there are no PS?
Sorry?
There are no PAS
No.
over there?
No, there is. So actually on table, there was a tag. There was a single tag, probably because of the trauma, which was holding on to the pupil. But that was not the only problem. The problem was also the updrawn pupil. So what we did in this case was we used iris diathermy, unipolar iris diathermy on the inferior part, and we recentered the pupil and released the tag superiorly so that the pupil came to the center.
what lens did you use?
Sorry?
What lens did you use?
Lens, we used a normal monofocal laser. Yeah. So these were the various, and then a little bit about angle alpha. Since we talked so much about premium IOLs, I think this is the last 2 minutes, then the next session could be ready. Since we have talked so much about premium IOLs, what is your cutoff for angle alpha? What instrument in your clinic do you actually use, and what is your cutoff? Dr. Kumar?
I have a pentacam and I have an anterion. Unless it's hyperopic, I don't pay much attention to this.
Dr. Nagvik?
So, especially if it's a multifocal IOL, I'm
Yes.
going to look at it a little more carefully. Angle kappa is what you measure. I get my measurements from the IOL master, seeing the thing. So, I get the IX and the IY, and I look at what is the. I actually do a little vector mathematics to find out what it is. So, if it is more than 0.5, I've been a little skeptical. But I've been surprised sometimes that even with a 0.6, patients sometimes do very well.
This is, I think, overrated.
Overrated, yes, I
It's
agree.
overkill. Patients neuroadapt beautifully because that's how they've been seeing through that angle for so many years.
Yes. So on IOL Master 700, you get what is called a CWC, that is the Chang varying chord. And ideally, theoretically, 0.6 is the cutoff. But even in my practice,
Multifocals,
have you ever rejected a patient because of high alpha?
Never.
Never. Suppose it's a high hypermetrope with, say, a 32 diopter lens. Then would you reject?
No.
No?
No.
So you'll be surprised. Technically, hyperopic LASIK is a contraindication for a multifocal, right? Because you're creating the same bad things for both the cornea is bad and the lens is bad. But I have done at least 6 patients, so 12 eyes, with hyperopic LASIK and a multifocal, trifocal IOL, and patients are extremely happy.
No, why I wanted
So-
to ask is this
No, what I
angle
meant
alpha
was-
is specifically for high hypermetropia.
Yeah, but they adapt very well, according to me. I have never rejected a patient.
Aldipurkar sir, your inputs.
well, I mean, 0.5 is a cutoff for me for both. But then I have no experience with doing it for, high hyperopes because I wouldn't be very keen to do it for more than 30.
My first encouragement came from a patient himself. He said, I never saw well for distance nor for near all my life. So, doc, do something for me. I explained that this is likely to happen. He said, do it. And I did it. And he was like 6 and 5 the next day. So, the next day, there was no question of adaptation. So, I think, we have to also always look at what the mindset of the patient is and what the patient wants to do from these cases. So maybe it's not a bad option to do. Yeah.
Thank you so much to all the esteemed panelists. Any questions from the audience before we conclude?
In presence of ERM, if there is no VMT or no CMT is normal, whether you will prefer multifocal and if it's panoptics or EDOF VVT. and patient want to get rid of glasses.
I would not. I've not had a very good experience with epiretinal membranes, because even if you do I've done a trifocal with an epiretinal membrane, and patients are 6'12" and they don't read N6. So I've already experienced this. So from now on, I do only EDOFs. I don't like VVT, so I do only eye hands. And I tell the patient you will get reading. So if you don't want glasses, it's better to live with the epiretinal membrane, because we don't know how it's going to behave over time.
How it's going to progress.
Yeah.
Thank you.
So thank you very much to the esteemed panelists as well as to all the audience. A very big round of applause to all our panelists. Thank you very much for your kind attention. Thank you so much.